So this is John Goehle with the ASC podcast with John Goehle. We will be going live in approximately 3 minutes. Go ahead.
Welcome to episode 91 of the ASC podcast with John Goehle for March 13th, 2020. We're recording live from our studio in Spencerport, New York. This is Sue Cronkite, Chief Researcher for the ASC podcast and Senior Nurse Consultant for Ambulatory Healthcare Strategies. And in our studio, we have Jenna Alvarez, Senior Nurse Consultant with AHS, Alex Bornemann, Director of Operations with AHS, and John Goehle, who is recognized as one of the nation's leading experts in the ambulatory surgery industry. And remotely from Cape Cod, Laurie Roderiques, Director of Clinical Services for AHS. Welcome, everybody.
Hello. This is exciting. Laurie, are you there?
I don't know, am I?
Yes.
You are. We can hear you.
Laurie's the only one that's not in the studio, so
Yes.
And my microphone is way too high. Hang on. So I want to thank everybody for joining in. So far, we have 19 people online, so clearly you got the message. We can take up to 300 people, so hopefully we won't use that many. So just a couple things. From a personal standpoint, I think it is important before we get into this to make sure that we take care of ourselves. You know, stay safe. Please don't panic. You know, I mean, this is not Ebola. That's not to minimize the consequences of this, but certainly this is not a situation where we need to be panicking like, unfortunately, a lot of people seem to be doing right now. So take care of yourself and your family. Just FYI, for your home, you know, prepare for an extended period of time in isolation. Prepare for a loss, like the loss of utilities is unlikely, but you do want to stock up on food and supplies without having to go out. Exercise good hand hygiene. Remember to use soap and water because that really is the most effective way to keep yourself safe there. We don't use a hand rub so that you can save it for those times when you can't get a hold of that. A couple housekeeping items. This is our first time, and we're just learning how to use the software. We did a test this morning, which worked out very well, but we do apologize ahead of time for any technological glitches that we might have. We are recording this. We are also doing a video feed, so you can see all of our wonderful faces, except for Laurie. We couldn't get her in the video, probably for good reason.
Yeah,
Oh, leave her alone.
absolutely, John, absolutely.
And we'll post these things as soon as we can. We'll probably edit the podcast a little bit. I'm looking at Sue, who's our editor here. She'll want to edit herself out most of the time.
Problem is we're videotaping, so you're
Yeah.
going to see me talking, and I'll cut out the words.
So it will be recorded. We'll put it out there as quickly as we can. Already our podcast earlier this week on the coronavirus is one of the most listened to podcasts in our history. Hopefully everyone has figured out how to use the app on their smartphones. Clearly 28 of you have. I'm sure it's growing by the minute. So we are actually just I'm just doing a little bit of banter before we get into the details, just to make sure everybody has an opportunity to log in. So I'm actually holding off on the content just a little bit for that reason and doing some housekeeping. If you want to ask a question, there are several different ways you can do that. We are monitoring in the studio the texting within the app. You might see that there's a place that you can input any messages there. We will be able to see that in the app. That's how we can see people logging in too. We are also taking messages through our website, and that is comments@ascpodcast.com. Sue is monitoring that on another screen. And then we do have the call-in capability. I see that a couple of you have been trying to call in. We're not taking calls right now, but I can see when somebody wants to talk, and we are going to allow questions as we go through, but we're going to obviously want to make sure we get through the content.
And just make sure everybody's on that needs to be on, and
Right.
and giving people a chance to get signed in.
Right, and be respectful. Obviously, here this will be recorded for YouTube. Any profanity or anything like that, I don't expect that from my audience. But that will.
I will do my best.
And calling in from the centers, obviously, we don't need to know where you're calling from.
That's right.
Just
That's right.
any questions.
And if you are going to call in, if you want us to want to call in, they do recommend that you use a headphone if at all possible. Just using, I think, Laurie, that's actually what you're doing. You're just using a regular headphone, correct? Like a regular iPhone, a headphone type thing?
Yeah, my earpieces that are in my iPhone.
Oh, got it. Okay. So that'll show you the type of quality that we have here. We're actually kind of amazed at how well this technology is working, given everything else going on. With that, we have 37 people online right now. It is growing by the minute. We're about 10 minutes in. We're going to try to keep this to an hour. The president is scheduled to speak at 3 o'clock. We've heard that he's going to be declaring a state of emergency. At some point, Alex here is going to talk a little bit about what that means. I did want to start by just going around and talking with the staff here about some of the things that have been going on, just to give you some ideas about the issues and how we're dealing with it. So I'll start with myself. Obviously I've been dealing with pretty much the crisis situation. So we have been working. Literally all of us here in the studio have been working with very limited sleep because of everything going on. I've been dealing with a lot of the bigger issues, as Jenna and Laurie have been dealing with the infection control issues. Thank you, by the way, both of you. You've done a bang-up job, an incredible job here, and I'm choking up a little bit, and dealing with everything. And also, I've been trying to predict what the long-term impact is going to be, and we're going to talk about that a little bit when we get into more of the dialogue. But be prepared for some pretty significant economic consequences of this, not only personally, but also in your companies. And we're going to talk about some of those tough decisions we're going to have to make. Jenna, why don't you? Jenna has been taking the lead on developing the roadmap. We're going to give her a much longer time to talk, but why don't you just talk about some of the experiences with your clients in the last couple of days?
So I've been mostly helping prepare my clients for, screening their patients appropriately, making sure that they have the appropriate protocols in place to deal with a potential case or a suspected case of coronavirus, making sure that they're appropriately educating their staff. Right now I think a lot of people feel like the situation, they don't what can you do right now, other than watch and see what happens. And so any bits of education we can provide our staff, making sure that everyone is knowledgeable about the situation and up to date about the situation, I think is really important. And then also preparing a drill to do for our clients, because again, if you have a potential case, you want to make sure that that's not when you're finding out, we don't know where the isolation stuff is. What was the last thing I've been doing this week?
Preparing all of our forms. And actually, that's something we should point out is that on our website at ascpodcast.com, we have created an action plan, 7 steps that you should be taking immediately. If you have not seen that, we really recommend that you look at that either as we're going through here, if you're able to do that, or certainly afterwards.
I think we're going to be updating it.
We're going to update it, and it already is 24. No, I mean I think it's about 12 hours outdated. So we
yeah,
can update it.
We literally yesterday were about to send out a protocol to all of our clients, and then the CDC changed their guidance.
Yeah,
had to quickly change it. So. And who knows? I know I've been closely monitoring New York State. They haven't released any new guidance yet. So we were going off of that for a lot of our guidance in terms of who needs to be quarantined and isolated. And before they were saying that anyone who's a level 2 travel notice from the CDC needs to be isolated and quarantined. Now that's the whole globe, so I'm very curious as to see what they're going to do for all of the people returning from anywhere in the world now.
Right.
Getting guidance on that.
Moving on to Sue, you've been fielding questions from some of our clients. Do you want to talk a little bit about some of those, and particularly mention that issue that we had in Buffalo?
Okay, so we've been talking to clients about how to screen their patients when they come in, hopefully pre-procedure phone calls asking the questions, which we'll discuss further, and we have in our resources, just asking them the questions, Jenna said, from where, if they've been traveling, and if they have any of the signs or symptoms, the cough, the fever, the shortness of breath, and just trying to screen those patients before they come in. And then there was an issue with one of our clients where one of the, I believe it was a CRNA,
Correct.
Came in with a high fever. They had recently traveled internationally, and
In one of the countries that had been in a level 3.
A level 2.
Level 2,
Level 2.
sorry.
And so they were pretty concerned about that, and we provided the number to call. And it turned out the incubation period, it was a longer incubation period than what they would be concerned about. So they actually they tested for flu and found out the
rapid
employee
test.
did have the flu. So it doesn't rule out having COVID, but they are pretty comfortable that that's what it was. So it points out that anybody coming in with any type of issues, they just should stay home. You know, you don't want to cause a panic, and you don't want anybody to get the flu anymore. You want them to get anything else.
Right. Alex, just before we went live, you got an email from one of our clients, and you've been fielding a lot of questions from yours too.
Yep. We had a center that actually had to shut down due to actually having a number of exposed staff members that tested positive for COVID, and that actually got through a sales rep. So definitely keep in mind that you should be screening all visitors to your center, including staff members, including us if we come to visit.
Well, we're not going to be doing that.
Nope. But if we were, we'd want to see that you're screening us. And for that matter, if you have any surveyors, be sure to screen them as well.
Can I jump in on that, Alex?
Yeah, go ahead.
Sure.
I would recommend that if it is possible to not have sales reps come in, that would be your better way of reacting. There are some circumstances, depending on your surgeries, that you require the sales rep, or if your staff are in the process of being trained on something new, However, if it's just a routine checking in, see how you're doing, I would advise that you just ask them to come in on time, or, send out a word to all your reps that you'd like them to make appointments.
Absolutely.
I know that they sometimes just show up, but, I think that's, the less you invite in, the greater your chance of not being exposed from unnecessary means.
And Laurie, what do you think about medical students and residents and students in general?
I would do the same. Obviously, everything you do goes through your governing board, but I think this is the time that you don't want to have them in. Not just to protect your patients and your staff, but also to protect them. Colleges are closing, so why would it be okay to have students come into your center if they can't even sleep in their own dorm rooms? So I think this would be a good time to suspend their activities at your centers. But again, that's a discussion that has to be done internally, and your governing body has that final say. But as an infection preventionist, I would encourage you to stand up for that, for that charge, to not have them come in, not to have any unnecessarily any people in to your center.
Absolutely. And we had another couple questions actually about whether centers should be canceling patients with elective surgery, especially that have traveled within the states. And as far as we've heard, there's no guidance as far as canceling patients for traveling within the U.S. But again, so at that point, it comes down to what your facility policies are or protocols for COVID. And if you don't have any, now's the time to establish them. Absolutely.
Sure. Yep. Yeah, no, and I would agree with that. I mean, if it's a healthy person coming in that's from out of town, and if they came via plane, train, or whatever, you would screen them like you would someone that's down the street, because, odds are they could have gotten it at the grocery store. So I would just be diligent, treat all your patients the same, offer that patient the right to reschedule if they should choose to. But obviously, if we have patients come to us from the islands. So they come from Martha's Vineyard, they come from Nantucket, and take the steamship authority boats over to the mainland to have their procedures done. So if they don't have any signs and symptoms, why would you turn them away as you wouldn't do with the people in the next town? So again, it's going to be all internal decisions. Have the physicians on board as well, because you don't want to surprise them with anything that you recommend if they haven't been part of the process of, putting in their 2 cents.
Laurie, I'm going to go a little off our script here. Not that we really have a script. But we've had a bunch of questions here, and I just want to open this up to everybody. First of all, one of the questions was, if a patient comes in with 100.5 fever, should we contact DOH? They have no other symptoms and no travel. I think the answer to that is that I don't think we have to contact DOH, but I would send them home. What are your thoughts?
Yeah, if it's a, I wouldn't do DOH unless they hit other portions of the criteria. At that point, I would decide, is this an imminent need for the procedure? Most ASCs, it's not. So I would have to, err on the side of caution and, wait till their fever goes down. And hopefully it really truly was just a fever because they, had a stomach flu or whatever. But you're opening the rest of your employees, your clients, your practitioners, everybody up for an exposure that you don't want to if you don't have to.
Right. By the way, we're up to 56 listeners right now online at this time. Total of 62 of time, and it just keeps climbing. So thank you, everybody, and we'll try to make this the best use of your time. Other question is very important. Somebody has asked me what website has the information. It is ascpodcast.com. If you are on the app, I did type it in there so that you can probably click on it right away. And, of course, we'll be posting it on our LinkedIn account. And email us if you need any other information at comments@ascpodcast.com.
And maybe explain the setup. So you've got all the links.
Jenna's going to go into that in a
Okay,
few minutes
okay.
here. I did want to answer questions as quickly as we can here because I know that that's very important here. If a patient, I got that one already. Somebody was asking when we talked about screening, what did we mean? And to that end, we're talking about the questions that you would ask. Do you want to quickly go through that, Jenna, the two questions that should be asked, or as of right now anyway?
So as of right now, you're definitely going to continue your screening of have you had a fever, cough, or shortness of breath, or are you currently having fever, cough, or shortness of breath? The other thing that we're recommending you kind of start thinking about doing is also asking if the person who is driving them today have those symptoms as well. And then the other thing is, before they even get to the center, reminding them, bring only one person with you. That'll both decrease the number of people in your waiting room and how closely together people are, but also decrease the risk of someone bringing the disease into your surgery center. So definitely asking about symptoms. I think I looked today, and the number one symptom of the disease is fever. I think 88% of cases presented with fever, around 68% presented with a dry cough, and about 38% with fatigue. And then it kind of goes down from there. Shortness of breath, I think, was around 18% or something like that.
And we're going to talk about perhaps implementing additional steps with regard to monitoring in a few minutes.
Yeah, but again, it's flu season, so
Right.
Screen like you're screening for the flu still. And then also as of right now, I would still recommend screening for travel to any of the affected countries.
Right.
Definitely any of the countries listed listed on the CDC website with a level 3 travel notice. Right now, CDC is recommending a 2-week quarantine from people returning from those countries. I'm trying to pull it up right now. It changes frequently. Right now, definitely China is still on there, Iran, and most of Europe, and you'll have to go onto the CDC website. That will be on the ASC.
It is on the links.
A link will be there for you.
And I do have to update the links, Jenna. There's a couple that just we'll get more information. I'll take care of that.
And
after the
South
podcast.
Korea. So China, Iran, most of Europe, South Korea currently have level 3 travel notices out. And when you go into the information about them on the CDC website, they say travelers returning home from specified countries in Europe must stay home, and other level 3, must stay home for 14 days after returning from travel, monitor their health, and practice social distancing. So you want to support the CDC recommendations, or do that. Level 2 is the rest of the world. So before yesterday, we were recommending that if you were level 2, even though they don't technically say to quarantine, for a level 2, that you also screen for those and exclude those. Until yesterday, Japan was the only one on that list, and then as of yesterday, it's the whole globe. And right now they're saying that travelers returning from international travel should monitor and limit interactions with others for 14 days after returning from travel. So that's something that centers are going to have to make the decision about. Do you exclude all patients with international travel? Do you use certain countries?
We actually just got a question on that, right? Somebody wrote in and said, I thought that since it is now community acquired, that we're not taking travel into consideration. But
I guess
no, you would
go
still
ahead.
take travel into consideration, but you might also, look at your community. And a perfect example of that would be, the recent outbreak down in New York from
New Rochelle, yeah.
Right, New Rochelle. That unfortunately, they traveled back and forth to the city every day, and that was a huge widespread. And up here in Boston, they had a conference where the majority of the cases being, claimed in the Massachusetts area are linked to that specific conference. I think it was a Biogen conference. So, you take that into account. But no, definitely still the travel is imperative. But, not to belittle anything, all of you, I believe, have been doing this for years. Ever since we had the Ebola outbreak, you've been screening your patients with the majority of these questions. Although back then we were asking if they've been, to the regions where the Ebola outbreak was. Now you're going to conform that to almost any travel that's out of the country, and possibly, if you're a frequent traveler, as some people are, depending on their businesses, they can come and contact it just via, the airports and whatnot. So
Yep.
You take what you're doing and tweak it, but you're not going to recreate something that you already have in place. You're just going to expand upon it, and you're going to make it more robust. And your second line of defense, besides your pre-op phone calls, you're going to rely heavily on your front desk admissions people, because they're the next step of who's going to screen who's coming through that front door. So they should be very well trained, or you may want to have your nurse up there, or your infection preventionist, or your pre-op person up there with them, because they can stop someone from coming through to your, restricted area. If they have a fever, if they were traveling and they forgot to tell you, as many patients forget their meds or other things. Oh, I forgot. Yeah, I had breakfast. Oh, yeah, I forgot I was just in Iran last week. It happens. It happens. One day runs into 20. But that's another, that's another stop area where you can possibly, avoid, other people. And at that point, you're going to have them put a mask on if they're hitting your yeses, and you're going to ask them to, either go to the corner or step out into the hallway, or if you have a room that you can bring them into. Whatever you've set up at your center, because every center is different. We're not all created equal with the space and the resources that we have.
yeah, you have to come up with your own with your own answer. And we do have another question. Linda had written in that they had an anesthesiologist who said their hospital is having them reuse their face masks for multiple cases, not just the N95, because all masks are on allocation, and wanted to know our thoughts on that.
Okay.
And we've had different variations on this question.
Well, and also we had somebody ask about, Laurie, we had one of our clients, remember, asked about reusing gowns too. So you might want to talk about both of those.
Yeah, the whole thing.
The problem with reusing your PPE is that you are now putting from one patient to the next patient to the next patient to the next patient. That's number one. Your masks theoretically have, a lifetime, as in, after so many, 20 minutes, whatever, you could read their packages, they get moist. So now they're not really protecting you anymore. They're not necessarily protecting the people, that you're caring for, but to have them come up and down and to reuse them is poor practice. Do we do it? Of course, I can't go into any center, and I won't say that I'm not also, an offender, that for years we took our mask down, went out, met the next patient, put it up, brought them in the room. Is it good practice? No. Is it best practice? No. But if it's all you have, it's all you have. don't not buy or put yourself out there to be in line to get things because you don't have them today. But, you have to be really smart about it. And to reuse gowns, in my opinion, is very poor practice because that's where you're covered. If you just did a case and you don't know what might have splashed on there, and unfortunately a lot of it is airborne, and this is an airborne virus. So it's really, you have to, that's going to be a personal decision for your facility, on a legal type situation or a professional infection situation. The best answer is no, don't do that. But what can you do? And the question about the gowns, John, I know one of your clients asked about cloth gowns, having them washed at a facility where you get your scrubs and whatnot washed and brought them back in, and then you yourselves at your center wrap them and sterilize them. I haven't had a chance to really research that, but the reason we went away from the cloth gowns was because they were no longer efficient in protecting the person that's wearing them.
Right.
Because of, the impermeability or lack thereof. So that would be something you'd have to look at. You'd have to look at your sterilization method. You'd have to look at your products that you use to wrap. Are they all up to textiles, since we've gotten away from that for years? And again, I haven't really researched it, but that's just right off the top of my head. That's a lot you're going to have to do to make sure that you can back your decision and that you weren't putting people at risk.
Right, and of course, from a legal standpoint, if anything were to happen, and not to mention, by the way, our patients are going to be watching us, and if they see us practicing poor, technique, you can pretty much guarantee they're going to be contacting the Department of Health, which will force us then to, deal with it. So just be well aware of that. We're going to talk about that in a few minutes. We did get a question. What if a doctor is returning from Belize? We did double check, and Belize is not on the list. Correct,
I'm not
Jenna?
seeing it's saying that they don't have cases as of like a week ago. I don't know if you.
Yeah.
Yeah, I can try to.
I'm actually looking at the website, a website that was refreshed this morning. No, they're not necessarily there, but it doesn't mean that the person's not an issue. You're gonna, I don't know if you're gonna be able to go country to country.
Yeah.
That would drive you guys crazy, but I think when you make whatever you decide would have to be across the board. And again, you would just watch them or anybody for any signs and symptoms. You're going to screen your doctors, your staff, however you decide to do it.
Would this be a good time for temperature monitoring, Laurie?
It could. It's not going to hurt. I think a lot of the healthcare agencies or whatnot are being encouraged to do that. I think as a person at home, to take your temperature every day would be as if I wanted to weigh myself every day. I'll drive myself crazy. But in the healthcare environment, yeah, it certainly wouldn't hurt. There's no issue with that because since that's one of the top, the number one indicator, but again, does a temperature mean you have it? No. Then you would do the rest of your questions.
We are 36 minutes in, so I'm going to have to skip through some things. We're going to obviously have to have another episode at some point, and I'm going to try to address some of the major things. I'm going to skip the economic issues right now. I did have a section on Joint Commission and HHC. Laurie, you and I we're both HHC surveyors. We have been told that they are going to continue survey activity, including deemed status survey activity. However, this is a daily issue, and our concern is, of course, for the health of our surveyors as well as our organizations that might be subject to a survey. So I think it's fair to say that the situation is very fluid there. They are extending your deemed status or your HCCC accreditation if they're not able to get out there in the meantime. I guess that stands to reason that would happen. I have to admit, I haven't gotten any communication from Joint Commission, but on the other hand, I only reached out to them once. We will try to keep you up to date on that, and perhaps at the next episode. I have invited both of them to talk to us on the podcast, and we'll see if that can actually happen. Yeah. Do you have any other observations, Laurie, on that one? I know you've been a little bit more on the emails than I have about that.
Yeah. Well, I know that I can only speak for AAAHC. I know that they're asking me if I'm able to do surveys as of today. So they're still putting them out there. And that's deemed status versus non-deemed status. So they're setting up surveyors to do all walks of surveys still. So unfortunately, the coronavirus is not the time that we can sit back and say, "Whew, they're not coming."
That's right. No.
Obviously, they are.
Well,
So still be alert.
That's right, and they're going to be focusing very heavily on infection control, and they have stated, as we've mentioned a couple times, if you've got an infection control issue that they find during a survey, they're not going to fool around. It's going to be immediate jeopardy, especially if it's obviously severe. And if you have been cited within the last 3 years for infection control issues, and especially if you have been cited at a condition, or at a immediate jeopardy level, expect DOH to be out there very soon, or whatever your state organization is.
Yeah.
Jen, let's move on to the action plan. On our website at ascpodcast.com, we have created a 7-step list of things that need to be done immediately in your organization. That's meant to be kind of a simple step-by-step thing. Just follow the links right on the cover page. I've tried to make it as obvious as possible how to get into it. I think it actually says link to action plan now. So please review that. If you're online and have that in front of you, Jenna is going to quickly go through each of those line items and explain what we've given you. They will change. She's going to speak to what's on the website as we speak, but I will be updating that sometime this evening with up-to-date information. So go ahead, Jen.
So definitely check the CDC website. There's the information for healthcare providers page, and then there's a bunch of sub-pages from there. I would definitely stay up to date with the most recent criteria for testing. Stay up to date with the latest infection control changes. I know it changed on Tuesday of this week, I believe. They relaxed the rules a little bit about using N95s and said you can use an N95 or a normal surgical mask in certain conditions, and also gave some guidance as to how to prioritize more for hospitals who needs a negative air pressure room for isolation. So
to that point too, Jenna, we did have a question earlier this week, the difference between a surgical mask and a what was the other term?
A procedure mask.
Procedure
that was
mask.
something Laurie looked into.
Yeah, they have different levels, level 1, level 2, level 3. The level 1 obviously has the least amount of protection for anybody. The level 3 is the higher one. The level 2 is a standard protection. In going back and forth, I think again it's a half of one and the other half the other. As long as you're wearing them correctly and they're fitted to your face, a 2 or a 3 is okay. A 3 is most protective, especially with fluid type exposure. So if you have a lot of shoulder cases, arthroscopies, if you're doing a lot of irrigation, depending on the procedures that you're doing, then if you could get the 3s, that's great. If you're doing basic cases where exposure is minimal and whatnot, then 2s are fine. Fortunately, one of the sites I was going back and forth with, said that AORN recommends, says it's okay to wear the ear loop masks, but again, you want to make sure that it fits you well. A level 2 ear loop mask. So unfortunately, we're having difficulty getting masks, as you all know. Actually, today I saw a family go by. They were wearing masks and gloves in their car. on the street, which I thought was kind of exciting. And I was like, well, there they go. There's our masks. But unfortunately, our hands are tied right now. We have to do what we can do with what we have. But the difference kind of is that it's the filtration. There's also high filtration. Laser masks have a higher filtration than an actual mask. It's so you can drive yourself crazy. You just want a mask that's going to protect you, that's going to be fitted well. One of the things I presume they're still telling people when you're in surgery, especially if you are at the surgical field, if you do cough or sneeze, don't turn your head because it comes out the side of your mask. It sounds rude to be forward facing. If you can step back, that'd be great. But, again, when we turn our heads and we have that gap in our mask, it's going somewhere.
Makes sense.
So that sort of thing. But there's not a big difference. Just look what's out there, and then your centers will decide what is best for you. And then, of course, it's what you can get.
Yeah, thank you.
Jenna, keep going on number one there.
Okay,
so we're still on number one.
The CDC website, check your state Department of Health or whatever it's called in your state website. I know. And
we have put links to the major websites. They're not on this action plan, but on the main page of the surgery of the ASCpodcast.com, and we'll keep trying to update that. And by the way, thank you for everybody that has been helping us out. If there are links that you want on that page, please send them to us. We'll try to update them as we can. With 50 states, what we've actually done is we focused on the states with the biggest population, and not to minimize everybody else's state, and I apologize about that. I did want to welcome also, I'm sorry.
Somebody.
Beth LeBoyer from California was finally able to get on, and I know she invited everybody from her state. So I know we got a heavy California and New York attendance here. So we'll try to answer any questions that are specific to those states, and we'll try to get those links up on the website. I believe they are there already. But keep going, Jen.
And then also your local Department of Health or Health Department, make sure that you're keeping up to date with their guidance as well. So CDC, state, and local health departments. Those are like the three key ones. World Health Organization also has some great resources up there. And as we find new resources for you, we will definitely share. I think now is the time, one of the CDC recommendations is to, during a pandemic is to, coordinate with other people, meet with key collaborators, and I think now it's the time that the ASC industry and the healthcare industry in general has to just come together and provide whatever help. And when someone experiences something and learns from it, share that knowledge with the rest of the industry. And I know there's been some great conversations both with the New York State members of the New York State Association. There's been some great conversations on the ASCA Connect website. So, and definitely we will provide anything that anyone sends us.
Right.
If you guys have a better way of doing it, I definitely am always on ASCA Connect. I'm always on, the other websites that have, to see what other people are doing.
We probably should put links to our email addresses on the website too. And it's a funny thing, I just never bothered to do that, but we'll put that up there too. We might regret that. Moved. I know we might regret that one.
So next is keeping your or making sure that your employees remember to stay home if they're sick or if they have flu-like symptoms. That's a good practice to have during flu season in general. Like we said, we had a scare this week because someone showed up to work with a fever and a cold, they showed up to work with the flu. So make sure that we're reminding staff to be aware and to be responsible.
With that, Jenna, it's sometimes very difficult, staffing wise, as you all know. We've all been there.
Mm-hmm.
You might want to encourage your centers or your center leadership to get a phone tree, because if somebody can't make it to work, maybe they can help you, you as the manager, find someone to cover for them, or another way, just to talk with each other and stuff, because that's how we're gonna get through this together. This is definitely a team atmosphere, and it's going to end, but it will take everybody's input and working together to help. So that might be something, because staffing is tough, and then you can't do your cases if you don't have your staff.
So next is, if you do have employees that have traveled to any of the affected areas, to encourage them to follow CDC guidelines and self-quarantine. You're going to have to make up decisions again about people. I mean, definitely the level 3 travel notices follow the CDC guidelines. You guys are going to have to make the decision what to do in your center regarding travel from other places. The other thing to consider is, because from looking at how it spread in China, a lot of the spread was in families because of the close contact. So if the employees have family members that are either infected or suspected to be infected, to self-quarantine.
Jenna, sorry, but that kind of goes to a question that we have. For employees we send home due to illness, specifically related to COVID symptoms, what guidelines can we give them so we limit exposure within the community and their families? So, I mean, we want them to quarantine, I guess, but we also maybe try not to put some space between their families, especially if they're living with their elderly relatives. I don't know.
Yeah, I would follow again your state and the CDC guidelines. I know New York State had some very specific, especially for people who had traveled, levels of quarantine, and then the CDC website definitely has some great information about quarantining themselves. I mean, I would definitely avoid, as much as you can, spreading it within your family, but that's going to be up to them.
And I don't want. I know we're trying to
getting
go
a
down
lot
the
of
list, but
questions.
we
We're
I
getting
want to
there,
cover the questions, because this is something we'd talked about before too. So Janet says that their local school district is planning on closing, and the employees that have young children will have to stay home to care for them. This will make a dent in our staffing. And I know we also were talking before about places where people rely on public transportation, if that's ever shut down. So it's probably important to start thinking about identifying people in your center. What would be the effect if either public transportation is closed down, if people with young kids, the schools are closed, and how you would manage that.
And because places where the schools haven't closed, I know a lot of my friends who are parents, the school districts have reached out to say, are you prepared if we do have to shut down?
Yes.
So I think that's something that could happen in the future, and that centers should get prepared for. And then, like we said, now I know as of today they had made an announcement for New York City, at least, that the rumors about the MTA shutting down are false, and that they plan to keep it open.
And I believe there's also a debate, or again, this is New York and New York City, that the state has basically said that even if the MTA shuts down, they might override them, correct?
That's kind of what the message from the governor's office said today. So it'll be interesting to see how that plays out. And again, we just don't know what's going to happen 2 days from now, let alone 2 weeks from now.
Right.
Yeah, so even conducting a drill or thinking, if you're starting to lose patients because people not wanting to leave the house, maybe just then talk through with your staff, okay, if we say we do have to cut back, who are the people we can depend on, though, to still be here no matter
and
what
Alex,
happens?
that was something that they talked about today.
Yeah. In New York, at the New York State, we had a little conference call before this, and they were talking a bit about the possibility of basically bringing people out of retirement, or maybe travel nurses from other states, waiving some of those processes. I mean, in terms of ASCs, I think we're lower on the totem pole than a lot of the hospitals.
Definitely.
But those may be options for us in the future.
One of our listeners just stated that the New York City mayor said MPA and schools will remain open. Thank you.
Mm-hmm. And John, this one's probably for you.
Yeah.
Saying that you mentioned the AAHC is doing deemed status survey still. Does that include new developments, or have they suspended them?
So I did speak to AAHC a couple days ago, and those are still continuing. And by the way, the states have been told to continue doing pre-opening surveys. It is important that we continue to try to keep the, providing services, obviously, and making sure we have the resources available in the future. The challenge that we're going to have, I think, is going to be resources. Like in New York State right now, many of the surveyors have been told to work from home. And I wouldn't be a bit surprised if at some point they're going to limit that. So I'm concerned that whereas they might not require it or might allow it to happen, whether the surveyors are, number one, going to be available to do it, and number two, are willing to do it is another issue.
Should we?
And just to talk to Janet's comment there.
Yeah, good point.
That's a very good point. And
well, did you see Janet's follow-up question?
Oh.
Saying will travel nurses put us at higher exposure
that's what I mean.
risk?
Yeah.
I want to make sure everybody sees.
Yeah, that is absolutely.
That is.
Thank you, Janet, by the way.
Yeah, I hadn't even thought about that.
And again, that is not that is not current in terms of being open and allowing travel nurses in without the proper procedures. That is just something that might be coming down the pike, but it might be just people from retirement. They might take that into account.
And to that end, Sherry asked, are there any laws in place for employers to pay employees affected by the school closures and daycare closures? I am not aware of any. Of course, you'll have to check your state laws, but of course, this could put a huge damper on small businesses. I mean,
and hopefully, maybe some of these emergency, when they're declaring states of emergency or something, maybe some financial help will come because it's going to put a lot of people in a difficult position. Right,
and somebody did comment here in our ASC, they informed us that the federal and state has made exceptions to the rule for people who have been put on leave, and they'll allow unemployment. I assume that is going to be one of the first things that'll happen is that you'll, if you do have to lay off employees, that they will be eligible for unemployment. Hopefully they'll be eligible without a waiting period for that. I mean, of course, unemployment pay isn't as much as what they're earning, but at least it's better than nothing.
When it comes to the planning of maybe not having staff due to school closures and whatnot, this might be an opportunity to look at your schedules and see if you can consolidate, from 3 rooms to 2 rooms, 5 rooms to 4 rooms, something like that, to plan ahead, thinking that perhaps you won't have as much staff, or running to 4:30 or 5 instead of 3:30 or 4, if that's doable, because maybe you could have staff that can do like a swing shift, because they can share, the moms can share with the dads, I can work till 12, you can pick up at 12, that sort of thing. Now is your time to be creative with your staffing, and definitely get the list of those that have no qualms about coming in. Parents with teenagers might be fine, or some of us more senior people that have no one at home, or and then there's those workers that have elder parents at home that need to be considered just as important as those with younger children. So, it's definitely a lot of brainstorming and outside the box thinking, do that risk assessment. Your risk assessments also involves your internal operations. It's not just what's happening outside, but it's what's happening inside too. And this is a good opportunity to plan and,
and whether having longer hours. If having longer hours, if they could, they could kind of thin out the crowd, so if they could still see patients, although they'd have to stay open later, so I'm not sure how that would work financially, but maybe then you have fewer patients in at a time. They can be spread a little bit more out, maybe cleaning between times. I'm not sure, but there might be a lot of, like you said, just being creative.
Yeah.
And I think,
hopefully it doesn't happen.
I think one of the key things is keeping an open communication between, your center and your staff, and your center and your your medical staff, making sure that if there are any cases of COVID-19 diagnosed, either the staff member themselves or someone in their close family, who lives with them, that you're aware of that. And then you'll have to, obviously if they have it, they need to quarantine for 2 weeks. With the family members, you're going to have to go with either your state or local guidance or, make the decision. Laurie, do you have a...
I did want to interject here. We're at an hour. We were only planning on 45 minutes. We are going to keep going, by the way. Thank you for everybody. We're still at 56 listeners that are live, and we've had a total of 100 log in. So obviously, I'm assuming everybody is... I'm assuming everybody still wants us to continue. We'll try to get through our contact. We do want to take listener questions. This is extremely important. That is what's taking time, and we'll schedule another one. But go ahead, Laurie.
Okay, what do you want me to go ahead with?
Oh, I was asking.
Just talk.
What do you recommend as it spreads in the community? If they have a family member, but the employee themselves isn't diagnosed,
Signs and symptoms.
Yeah.
Then you know what? Of course, that's going to become an internal decision. We would have to think, they're more apt to potentially be a carrier, although we don't know if you can just get it that way or if it has to be a live person giving it to you. I don't think so. I think it could just be coming in contact. That's, you might have to maybe delegate that person to do your pre-op screening if they're not coming in contact with other staff members or patients. That's a tough one, Jenna, and I'm kind of glad I don't have to make that decision.
Yeah.
Mm-hmm.
But at the same token, it is something for all centers to think about because eventually it's going to happen.
Mm-hmm.
But again, there's no script on that yet because when you think about if that happens to our major hospitals and healthcare systems, no one's going to be working.
Yeah.
Right.
That's just the nuts and bolts because they're coming in contact with the patients, never mind people that they're living with.
Yeah, and we did put up a letter to use as a template on the website to send out to employees or to use as an email, however you want to send it out, or do a
Email, right.
a little huddle or something.
Right.
Just make sure that you're communicating with your staff, and also let them know what you're doing to protect them.
Mm-hmm.
Yeah, that's key.
Why don't you go on to number 3, Jenna?
Number 3 is, we kind of talked about this earlier, is
Right.
the screening patients before services are provided. So this is really a time when you want to emphasize the importance of pre-op phone calls and pre-op screening, canceling patients if there's concern that they either have, coronavirus or the flu, because you don't want the flu spreading at your surgery center either. And then...
And you've posted a generic protocol.
Yep, we did
template.
a generic... I wrote that before level 2 involved the whole world, so we might be updating that. I think that's really up to you guys, what you decide, as we talked about earlier, as to who you're going to accept and who you're not.
And we do have specific protocols for some of the states. The New York one is up there. I haven't gotten the other ones up there yet, but I'll get the other ones.
The only thing is the New York one now is kind of outdated.
Is outdated, okay. And there is a decision tree, too.
There is a decision tree. Again, use it as a template. Make decisions about what your criteria is going to be, and then update it. And we'll be updating it as we see new guidance.
We did get another question about where to find this. As people join, they probably haven't heard us. So a couple things asking about where the generic protocol is. Go to ascpodcast.com and follow the link for the action plan. It's right on the web page, right center of the page there. Just click on that and you'll go right into it. And then keep an eye on it because we will be updating it as we go along. Again, feel free to put text us within the app. Email us at comments@ascpodcast.com. I am monitoring that. By the way, I've been getting a lot of phone calls while I'm on the line. I hope they're not people trying to call in because we don't have that capability, but they're probably our clients with questions. But that is not something we can do. We're going to be taking questions in a bit, so if you do want to call in, there is a link on your app that says, what does it say? It says...
I think it was
says-
just a little phone shape.
Right, and what does it say? It says something like
Caller number.
call in or...
Yeah.
Okay.
I think there's.
We actually don't have
Familiar.
the app running on any of ours, so...
So let me just
Go
get
ahead.
through
Yeah.
our thing real quick.
It was just a phone.
Our next is to make sure you're posting signs and alerts. We have a couple up on our site. I mostly stole them from New York State and New York City, and tried to make some generic ones for states that didn't have signs. But look to your Department of Health website or your local health department website. They might have things state specific. Definitely signs posted saying if you have any of these symptoms, let us know. And that goes for both patients and visitors. And then also there's some nice signs about stopping the spread of germs and hand hygiene, cover your cough type signs.
Hey, I'm going to jump in with a flight of idea because that's what I do best. The other thing that CMS had put out a little while ago is that they want you to get your, exposure, not your exposure control plan, but your infectious disease plan or your, whatever you name your plan as part of your emergency preparedness as well.
Oh, good point. Yeah.
Just thinking off the top of my head, that's something you want to consider, especially if you are a center that's technically at risk, of possibly having a surprise visit or that's planning to have Medicare deemed status surveys. That might be something that they look for. So
And we can
all
post.
have a policy regarding, do we accept communicable diseases, blah, blah, blah.
Right.
You just add it into that and then just make sure you refer to it in your emergency preparedness or you just cut and paste it into your emergency preparedness because unfortunately this is now considered an emergency situation that we have to be prepared for. So don't make a new one for your emergency plan. Take what you have, make sure it meets the criteria now with this new pandemic that's out there. So just add to your existing, and then, use the same template into the emergency preparedness so that it's, it's one and the same.
Alex, I know you're monitoring the president's speech, which I believe has just begun, right? But can you talk a little bit? I think what we do is we're making some changes to our recommended emergency plan. I know the emergency plan is quite big. Have we made change? There's two issues here. One is the pandemic policy, and the second is the emerging.
We have an emerging infectious disease policy, which we kind of tried to make as generic as possible to fit both COVID-19, but also, if there's another Ebola
Potential
outbreak,
future ones.
or if there's some, whatever comes in the future.
So
and-
we'll post both of those policies
Yep.
and maybe some recommendations, because I know one of the things that we found is that the disaster preparedness plans at a lot of centers are woefully inadequate or
Yes.
have been done so generically or with like with a hospital in plan. So we can't give you everything on that because it's way too much to put out there, but we can definitely help you with this portion. And we'll post that when we can.
But definitely add, if you don't have it on your hazard vulnerability
Yes.
assessment, definitely add pandemic if you don't already have it, and emerging infectious disease.
Let's post an HVA with an example of that. Do we have a couple, Alex, that we can put up there?
Yeah.
Just like an
Yeah,
example
absolutely.
filled out. It'll be in an Excel format so that you can modify it for your own organization.
Okay, so that actually hit number 5 on my list about looking at your infection control policies and your
We're getting
disaster plans, updating your policies if needed. Next is, and this isn't a requirement, this is a recommendation, performing a mock drill for COVID-19. We have a drill kit up with some, it's kind of more of a tabletop to do, though it probably wouldn't hurt to kind of go through how you would isolate the patient, where you would isolate the patient, how would the staff put on PPE properly. Again, we don't really want to waste PPE right now, but at least talk through it.
And to that point, having maybe the person who first admits the patient in, or whether admitted but brings them into the center, try to really limit the amount of people that have to have contact.
I know that's some of the things that we've seen. I think we put in the protocol is, as much as possible, have the same staff members providing care throughout, so that you're limiting the number of staff that are exposed to that person while you have them in your center. So drill is next, and then last is a little self-serving to John, but listening to our podcast for updates.
We will keep you up to date. We're going to do as many episodes as we have to here, and it is free. Please pass that on. I know some people are trying to capitalize on this. We're not going to do that. We definitely want to get this word out there, and we hope this is beneficial to everybody. So watch the website. We're going to go a little bit off of our script, everyone, just because we are at an hour and 7 minutes, and I think I wanted to get questions in. If we don't get questions, we'll continue with the script. But for now, if anybody does want to call in, please hit that call-in button. Thank you, Giovanna, for telling us how to do that. I think there is a call-in button on your screen. In the meantime, we did get a question just a few seconds ago. Can you speak to limiting patients 60+, especially those scheduled for pain procedures or GI endoscopy, since the elderly in a high-risk category?
Laurie, we actually talked about this earlier, because one of my centers has actually talked about talking to their physicians about looking at your patients with comorbidities that would put them at higher risk, and limiting those cases for the foreseeable future.
Yeah, and you don't want a patient to come back at you for age discrimination. It's not just employees that can say that, I'm sure. But I agree with Jenna. If you have a healthy 70-year-old with no outstanding processes in place, then why wouldn't you do them? You can have a 50-year-old that has emphysema and heart disease. You know what I mean? So I think putting a number, we know it's in most of the cases are 50 and above. I don't think anyone has been diagnosed under the age of 50, but that would put the majority of your GI and your cataract centers out of business if you didn't accept patients above a certain age. So that would be a discussion to have with your medical director and your anesthesia providers to see what the patient criteria, if you're going to change the patient criteria selection now. But I really don't think you can use age as that, except obviously with pediatric patients that some centers are not prepared for because of the lack of the number of pediatric cases that they see, and it wouldn't be safe practice for them. But
we have a phone call, right?
Yeah, we have Giovanna. I believe this is Giovanna, correct?
And an echo.
Giovanna, are you there? I'm going to have to take her offline because we're getting an echo.
Just while we're waiting, I wanted to mention we appreciate all these questions. It's great to hear what people are wondering and being able to answer something specifically. And it makes me think, just with our regular podcast, even though it's not live, it's not, immediate questions, but remember, you can also send in questions for that. And we'll get to them, and we'll get an idea of what people want to hear about.
Moving on to some more questions. We did have somebody ask, can you add a tabletop exercise template or guidance for conducting one on the website? I believe we have, right?
The drill kit the drill kit is probably more of a you could either do it as a live drill or a tabletop.
Okay.
Absolutely.
Yeah, so it is labeled as a drill kit, but it is it's focused on a tabletop.
Right. However you do it, I would run your front desk through the process, maybe multiple times with multiple different
scenarios.
Scenarios, exactly.
Because the other thing, this one is for a patient, but sorry, Laurie. This is
No, go ahead, Jen.
with a patient, but you might also want to run through a scenario for an employee or a rep.
Yeah.
We do have a listener on the line. It's Giovanna, a friend of mine, I believe. Giovanna, welcome. Can you hear us? Giovanna? Okay. Why don't we continue? Can you advise where the drill kit is on the website? Again, ascpodcast.com. Follow the link. Oh, I'm sorry.
One of the things that I would recommend with your tabletop drill or your drill kit or whatever is to actually have a drill kit.
Yeah.
Have a little, I don't care if it's a tackle box or something that would have extra masks, gloves, a thermometer, hand sanitizer in it, and maybe one gown, or whatnot. I mean, it's not like you have to
I
gown
know. Yeah.
when they're at their front desk, but if you have something in place so that that person at the desk has something to go to that is always going to be in the same spot every time, it's just.
We have somebody that is online that want to ask a question. I'm sorry, I don't know your name. I thought it was Giovanna, but
I think they have similar usernames.
yeah, you're live.
Ariel?
Ariel? Is it Ariel? Hello?
Okay, I don't know
May
what's
not be
happening
working
there.
correctly.
Okay, then it clicked
And
off.
somebody wanted to know where that drill is. So it's right in the kit.
So if you go to ascpodcast.com, there is a click here for action plan.
Go into that.
I'll be honest, I walked past it, or I had trouble finding it the first time.
Yeah.
But you added the click here now sign, so
I know,
now
'cause
it's
it looks kind of like it might just be a
title.
a title above the
It
things,
says
but
click here, and then under number 6.
and it's in very large print.
Right.
Look for that. It's one of the top lines.
Don't know how much more obvious I can
Num-
make
I
it.
know, but I totally.
Sue and I both
did the
had
same thing. And then when you go in there will be one of the lines is drill kit.
It does. It's item number 6, perform a mock drill for COVID-19.
And just an update from Trump's speech. He is late for it, so the podium is currently empty.
Okay.
So no rush.
We'll try to
Checking the
update you as soon as we hear. Did I get all the questions? Oh, somebody, Janet. Janet said we're currently limiting all patients to bring only one person, and we prefer that to be the driver. Most of our patients are happy to comply. And yes, I think that's a good idea.
That's great, Janet. And you know what? I would do that forever.
Yeah, good point. Okay. Again, we're taking listener questions. Just click on the call-in button. There's 4 slots there, or 3 slots there that are available. Just
there'll
click
be
on any of them.
number 2, number 3, and number.
Right.
Yep.
Whoop, and there we go. Let's see if we.
But I don't know if it's not working.
Okay, and you're live. Can you hear us?
Ariel Puchata?
I'm not sure who this.
Puchata?
I'm not sure who this. Okay.
I think we're at least getting feedback from our side.
I think,
Yeah.
maybe that they need it.
I think we're at least getting feedback.
Maybe that they need it.
Okay. Well, I'm going to have to cut them off because we're getting too much feedback there. But
sorry.
okay.
And
if-
just type in if you have a
Type in your
question. Yeah,
Right.
send us in the question. We're sorry about that.
I'm having a hard time disconnecting. I don't know what's happening there. Okay, there we are. Thank you. Okay. Thank you, Christina. Hi, Eric. Sorry, we couldn't hear. Okay. Any other questions? We're trying to follow everything that's coming in. While we're waiting for somebody to call in or send us a question, and we'll monitor it constantly, why don't we move on? Laurie, one of the things that you and I talked about is issues related to the center, such as social distancing and isolation. Why don't you and Jenna talk a little bit about ways that we can minimize, if we are going to choose to allow patients to continue coming, what we should be doing there in order to minimize the risks.
Well, the having the center that's having just the one person escort is perfect. That'll cut down a lot of activity in your waiting area. And unfortunately, the waiting area is really kind of tough, depending on the size of your center. If it's at all possible, maybe you could push the chairs a little further apart, or try to reconfigure a better way to organize there, because that 6 feet from each other is not always realistic, especially if you have a very busy center, and many of you do. That's kind of a tough thing. Again, the isolation is based on if you think someone has some of the symptoms or answer some of your questions in a yes response. Then you may want to make sure you have an area that you can bring them to continue the process of potentially admitting or sending home. Some places are encouraging the rides to go and wait in their car. I don't know how feasible that is. It certainly won't be feasible if you're in an area that does public transportation. But it's just kind of stuff like that is one way to look at it. Or if you are in a larger building that has a common lobby, maybe they could wait there. So again, could be more brainstorming with you and your staff on how you think is best to handle that. I don't know, Jenna, any more thoughts on that?
I was deferring to your expertise, Laurie.
Well, that was foolish.
I think we already talked about the screening part. Oh, this is a good question, Laurie. What should the role of the infection control coordinator be in all this?
Actually, before we take that question, we do have a live question. Alex?
Oh, yeah. This actually came from some of my clients prior to the call. And dealing with issues for staff wanting to go on vacation, I mean, I know I've got a vacation scheduled for
anymore.
May to Ireland, which has not been I can still go as of today. But yeah, definitely if your staff are going on vacation abroad, isolating them upon return for 2 weeks is probably the best bet.
Right.
At this point,
and making sure that we can't tell our client, our employees not to do something, but they need to understand that there might be some ramifications of that.
Absolutely, yeah. So obviously, use your best judgment on that, but yeah, tell them the ramifications if they do go on vacation. That maybe when they come back, they won't be able to come back to actual work for 2 weeks.
Even if the place isn't currently on a high list, although kind of most things seem to be now, but it can happen right in the middle of their vacation. You just don't know.
Our friend Janet
I have to make an addendum to my statement. A dear friend of mine, who is no longer my friend, pointed out that Johns Hopkins has recently done a study or whatnot, that the average positive on average are ranging around 45 years of age.
I think that's our same friend, Laurie.
Yeah, no, she was our same friend. But, and you know what the funniest thing is, earlier as I was driving, my husband was listening to talk radio because he has nothing better to do than drive himself crazy. The speaker was also referring to the Johns Hopkins study, actually in a wider sense, all the number of cases and truly how small the United States exposure is to this point, although it is, we are in panicking mode right now. But at that point, it was 50. So it's like, unfortunately, we have to really be careful what we see and what we read and take it with a grain of salt. So 45. I would go with that. I'd rather err on the side of caution. It's, it's kind of that way. Look at colon cancer now. It's not 50 anymore.
Well, we have to remember, too, that we're not sure about the denominators because people don't necessarily, first of all, we're not doing a good job of testing everybody. And so we might know the numerator, but we don't know the denominator with these rates of infection. We have a couple more questions here. One comment, Janice said we're having problems with patients stealing Masks and
Yes.
Purell right now, we've pulled them off the waiting area. Please, absolutely do that. Don't leave them out.
Have them available, but don't
Have
let people
your
just take
receptionist or
them.
someone at the front desk,
asking
you know,
and-
have them to hand out if you need them.
Right.
And as she mentioned, even better, just rescheduling people if they appear to have an issue. And then
Yeah.
Christina was wondering if you have a feeling that the State Department will issue a statement to halt all elective surgery.
Yeah, that's a big question right now, and that's been a big question that's been asked of us from our clients all day long. Is this going to get to the point where they're going to tell us that we can no longer do surgery? And I would say that is not out of the question. We're in unprecedented territory right now, and I fear that if they're going to try to reroute healthcare providers and resources, we're the first people to really be pulled out.
But
And with
well,
the PPE,
but
we're-
on the other
you wanna
hand,
save
when
it
you
for
think
that.
about it, we're also a great source of removing cases, and I'm not doing this as monetarily.
No. Yep.
Removing
Right.
cases from the hospital because they're going to be dealing with a much greater number of potentially much greater number of
Sick,
people that
really
are
sick
ill.
people, contagious people.
you know,
Yep.
so it can go either way. And the thing is, if they decide they don't want to do elective, they take away elective surgeries, are they going to close every restaurant? Are they going to close
Yeah.
every bodega? Are they going to, you know what I mean? To what end is this going to be? We always have a risk of not having a job, but I don't think we should get too wrapped up in that possibility because there's nothing we'd be able to do about it should it happen.
And don't you think a lot of it has to do with the availability of the PPE? Because if you've got plenty of it, the centers can keep working. If they really, really get into crisis mode with that, is where they're going to have to save it for only really serious surgeries.
Yeah, and to that end, Christina just asked, do you think there's a possibility that hospitals could reach out to us regarding the use of our PPE due to all of the shortages? Very good point, Christina. I did want to point out, we're getting a lot of, unfortunately, people that are trying to spam us. That's what we just figured out. So if you do want to ask a question, please text me so that I know you're a real person, and then hit the call-in button, and we'll let you in. Sorry about that.
Yeah.
Hate those fake people.
I know. That's what was happening. All those people that we were
When we
letting
kept
in.
trying
right
to-
there.
It's how you know you made it, John.
Yeah, I guess so. Have I gotten all the questions? I'm sorry. I'm trying to scan back. Our
I
feed
think
is huge
so.
here. I think we got
But
all
if
the
not,
questions that we have so
Please
far.
send it back in again.
Okay, continuing. Laurie, where were we? We're talking about social distancing and isolation. We're talking about the screening we've already.
So the infection control coordinator.
Yes, please.
He or she is going to be your go-to person. Now's the time to really, if any of you are administrators or nurse managers out there, to really back that person's position. When we were doing our pretend practice earlier, one of the things that I stated was that it's a good time to get your staff together, and the IP can coordinate this because they are going to also have to be very diligent in the surveillance processes of your center. Watch out for each other. Make sure that your colleagues are doing hand hygiene. Make sure that we are wearing our PPE appropriately, because it's not just going to be protecting that person that's not doing it right. It's going to be protecting the other people that person comes in contact with, which could be you.
Right.
So I think here's an opportunity for the IP person to, share that, not just share that responsibility, but also explain, see, this is why. This is the importance of our infection prevention. It's for all of our safety, every single one of us, and the kids at home, and our parents at home, and our loved ones at home, and the guy next door. So that's their role now, and hopefully, every IP person, or 99.9 of you, have other roles. So that's why now we have to share that responsibility of keeping us all focused and moving forward and doing things well.
thank you, everyone, for that. By the way, we're getting a lot of nice comments. And Jenna, somebody did comment about your policy example. I have to say that you have not gotten any sleep, and your dog is whining outside the studio door right now because he hasn't seen you in so long. But
Well,
thanks
also
for all
thank
your-
you, Laurie, who's my
Yes.
my
Oh, you're welcome.
my editor.
You guys are great to work with.
Our dear mutual friend, Christina, just texted me a question here. An ASC client has asked if the facility could be used for potential overflow. And and that is true. And we spoke to somebody yesterday who during Hurricane Sandy was actually required to open up their center. Was it for a local hospital? Does anybody remember that situation?
Was not part of
It was
the
not your conversation. I can't remember who it was with.
I wasn't there.
Yeah, I can't remember. But anyway, it was an organization, I believe it was in downtown Manhattan, that was required by the state to turn over their facility basically for, I think it was a half a day. I'm not even sure what it was for, but yes, the answer is it definitely. Is a possibility out there. And again, that should be something you should be considering in your, I mean, this is a good time to look back on your emergency preparedness plan and, to make sure that you've addressed all of these issues and that it's up to date because surveyors will be looking for it. Donna just texted us and said, yes, we could be asked to hold overflow patients. I agree. Yeah,
Remember all those facilities that say, yeah, no, we don't want you part of our emergency preparedness. That can change in a heartbeat, and yeah, you're going to have to comply with your region, state, or town ordinances. So, I don't think we'd have the right to say no.
We did have another question, or actually, I don't know if there's a question. Oh, there it is. Should there be a collaborations occurring between hospital infection control preventionists and the ASCs, and should we be reaching out to each other? That's an interesting question, Laurie.
I think there's always a good. I think it's always a good idea to have a collaboration with any infection preventionist that you can, especially in your local hospitals, because they're gonna they can help you. There's a lot of times that something small can come into your center and it's like, what should I do? Well, what's the hospital doing? What's the hospital's policy on this? And again, don't reinvent the wheel. And having a good relationship with other people that are possibly more in the know or better prepared is a good thing. I think having open communication with local specialists or experts or whatever the word you want to use is great. There is no I in team, and you're doing it. Most of you are doing it for patient safety, whether it's infection prevention or helping get supplies. I've been a firm believer of that for too many years, not just in infection, but overall. So yeah, now definitely it's not a bad idea to introduce yourself and get to know each other.
We're still taking questions. Our listenership is dropping a little bit, so I think people are starting to drop off, but we're still at about 45 people online at the current time. So email at comments@ascpodcast.com. Text, within the Podbean app. Text me at 585-729-8781. Send a carrier pigeon, whatever. Sherry from California, for facilities in California, if you go to the EDD website, it outlines waivers to extend disability for sick, quarantined, and caregiving. Thank you very much, Sherry. Laurie, I did want to point, while we're talking about infection control coordinators, let's just make a shameless plug here for Laurie and I are going to be working on doing an infection preventionist training program. It will be a premium podcast through this, kind of as an option for people that, number one, are interested in becoming an infection control coordinator, or number two, have become an infection control coordinator and need to have proof that they're qualified for that. And it's an alternative than some of the other options out there. You know, Laurie is a CAPE certified or certified person, and she is fully qualified, as hopefully everybody has learned by now through this conversation. And I think that'll be a wonderful tool that we'll have. Hopefully, Laurie and I will have some time to do that, and we'll get that out very quickly. But this is just the greatest example of how important it is to have a good infection control coordinator that understands what's going on, that has been trained specifically in ASC industry. You know, there's a lot of other credentials out there, but CAPE is specific to this industry. So just a shameless plug. Keep an eye on that.
Who gets paid for that commercial, by the way?
That's a good point from Chris.
Christina said, as a past volunteer firefighter, I think it's a great idea to reach out to your local agency who responds to your center in case of an emergency. A collaborative drill may not be a bad idea. Excellent idea.
Great idea.
And that's in general. That's not even just for this emergency here. When I was running an eye surgery center in Rochester, we coordinated with the volunteer ambulance right down the road from us, and it was a great exercise for all of us. We practiced actually taking a patient out the door. That's when we learned that like one of our doors was going to be a problem, and we learned a lot from that. So doing a real live drill, great example, Christina.
Yeah, and as a surveyor, make sure you write it up so you get credit for it.
That's right, and remember, everyone, if you're HHHC, you are required to do 4 drills, 1 each quarter, disaster drills. 2 of them are internal, 2 of them are external. Even with the changes in the CMS requirements that came into effect in the fourth quarter last year, if you're HHHC, you are still required to do those 2 drills. I do not think this in the next quarter are going to be a problem,
Right.
between what's really happening here as well as this. And if you need any tools, again, go to our website for that.
And going off of that too, you can write up actual events such as this
Right.
as a drill.
Up to 50% of the drills can be real.
Exactly.
Alex, I know you've been following what's going on. Is there anything to state?
No, the president is 30 minutes late.
Oh, okay.
But
On the other hand, in New York, they just announced that they're going to open a drive-through,
Drive-through
drive-through COVID monitoring testing center in New Rochelle. So.
If you're in
Yeah, I
New
heard
Rochelle, you have another option for testing. Can we just talk about this for a second? Is that I know what's going on with testing. Is anybody? I know, Jenna,
Not
you
as
expressed
many.
concern this morning that even though there's 1.5 million test kits out there, there was like a very limited number of tests that have actually been performed, and there's issues in getting tested.
So,
Or are there 1.5 million?
Right.
so I don't know how many are actually available. I know that so far we've done around 11 or 12,000 in our country. I know other countries are doing like that per day. So I'm not sure what's taking so long, but I think states are finally starting to really ramp up it's the testing, and I think that we're going to probably see quite a few more cases now that there's actually the ability to test. I know there's been a lot of, and again, look at what news you're looking at, but there's been a lot of reporting of people's struggles to figure out how to get tested. So it's probably state by state, but it seems like in New York at least there's been a lot of confusion and
I can speak a little bit to New York because getting off of that call recently, and actually the president did just show up. But for New York, what they were saying is don't have your staff members, if you're sending them to get tested, or really anyone, don't send them to, just the hospital or unless they really need help at the hospital. Call your local county Department of Health. And those are the boots on the ground in New York.
Okay.
and those are
That makes
those
sense.
they're the ones
And
who will be able to.
in Massachusetts, they just were allotted enough tests to do an additional 5,000 tests. This was as of I think this morning, on top of, I think they've already done over 7,000 tests. And I could be wrong with this assumption, but I believe that they're testing those that have showing signs of symptoms and not just drive-throughs, and that will be the issue. If they do people that are just want to be tested, that's going to waste a lot of resources.
Yeah, New York
So-
had outlined a couple days ago their testing criteria, and again,
Okay, good.
a lot of it was location, travel related, so I'm not sure if that will change in the coming days. Also, as community spread changes.
And again, I do want to remind, I know Beth LeBoyer from California is on the line, or is listening, and I know some of the other state people have been listening. Please feel free to send us any links that you want on our website. We are actually considering, too, the possibility of doing some live podcasts specifically for states. We have the technology. If you wish us to do that for you, we'd be glad to do that. Just reach out through, well, everybody should know how to get in touch with me, but comments at ascpodcast.com or JGOEHLE at strategies.com. All of this information is on the website. We do have another question.
It's a comment, actually, from Janet. She said a family member. Okay, and it's in California. Fremont went in for a routine blood test and was asked about symptoms and was told that if they were experiencing any symptoms, they could be swabbed right then.
Oh, good.
So I guess there is some testing.
So I think they're going to ramp it up.
Areas.
I mean, if you think about what happened when we had H1N1, everyone who came in with flu-like symptoms got swabbed for H1N1. So once, they have the capacity, hopefully they will be doing that.
Our listenership is dropping. I'm assuming people are have lives, so they're heading off.
It's been a bit long.
So we'll just we'll try to wrap up a little bit here. This will not be the end. We'll probably come back on. We'll try to schedule something. I know it's Friday the 13th. By the way, oops. Go ahead, Alex.
National emergency was just declared.
Okay.
We saw this coming, but.
And we'll try. So the question, of course, is what does that mean? I know I asked that 2 minutes before we went on the air, Alex, and you'll look into that, and we'll try to have some answers. We'll probably hear from the president too, as to what that actually means. Laurie, I did want to kind of finish just unless we have more questions, and we're monitoring for them. There's a high chance, as we talked about earlier, that you're going. That if you've had a problem in the past with infection control, or if somebody complains to the local health department about an infection control issue in your center, that you're going to have a sudden visit by the state or even possibly from HHC. And if you, even if that doesn't happen, if you're scheduled for a regular survey, you can pretty much bet that 50% of the time is going to be spent by your surveyor on infection control. Laurie, do you want to talk a little bit about what you look at when you're on site? I can chime in a little bit too, but you're the infection control expert here.
Well, I think that sometimes I'm over picky, but
yes, you are.
Thank you.
He would concur.
But I just really look at the processes. I look to see that the staff understand that what they're doing and why they're doing follows the protocol of, say, the manufacturer. When it comes to your cleaning process in your decontam and sterilization areas, that's important. Watching staff turn over rooms or do environmental cleaning, because environmental cleaning is so important. We don't even think about it. Making sure that we're letting our product stay on our surfaces as long enough for it to do the kill. Because what's the point? Why even use it if you're just going to throw the sheet on it? It's not going to protect the next patient. Things like that. I hate picking on anesthesia providers, but they are a wonderful source of job security for people like myself. Because we're always in a hurry. Every one of us is in a hurry. It doesn't matter what we're doing. But in our surgery arenas, whether it's hospital, ASC, or in the doctor's office, we always want to get it done and turn it over and go on. So we're cutting corners, and we can't cut corners anymore. We can't draw up those meds ahead of time. We can't put them in our draws, for the next patient. We can't not label them, because you know what? Things happen. Things happen, and someone picks up the wrong syringe and administers it, and then it's too late when the patient's having a bad reaction. Things are put in place for safety reasons. I don't always agree with them, but unfortunately, guys, I'm going to call you on it. Only because then I'm not doing what you're asking me to do, which is to make sure that you are the best that you can be. So that's kind of what I do on an infection control type thing. And as surveyors, I believe we all look at the prior survey. We look to see if you followed through with what you said you were going to do. I get a little cranky if I walk into a center that hasn't addressed anything from the prior survey that they said they were going to. Then I say, how dedicated are you to your staff and to your patients? And then I might be looking a little closer. So I don't like to see infection control, not be a forefront. Everything is just as important, but infection control can close your doors. Not having a policy is not necessarily going to close your door, but doing things wrong in the infection control arena, you bet you're going to close. So, look at it that way. And there's nothing worse than having your center in the paper because of something you did wrong that you could have avoided by doing it right. So that's my speech.
Mm-hmm. Good point.
Any other comments from our peanut gallery here?
Oh.
Thank you.
Well, so I guess Trump says 500,000 new tests available next week.
Yeah, they're
Don't
vastly increasing the number of tests. They just approved new tests from a few different companies in the private sector.
Good.
Yeah, and I think they've approved private sector testing facilities, so they don't have to go to the CDC. They can go to private labs, which
Well,
will
and that
help,
drive-through sounds
like
a great way to do it, though.
That's how
Well, they are.
That's
Yeah.
how Tom Hanks got diagnosed, I'm pretty
They
sure.
do- Yeah, you drive up and they just take a little swab, and that's a good way to get, to get numbers, and to get accurate numbers.
Okay.
All right.
Well, that's it for this episode, this live episode, which I think has gone off very well of the ASC podcast with John Goehle. Again, join us again, and please consider becoming a patron by going to our website at ascpodcast.com, and please spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. If you do hit the subscribe button, you'll be informed about the availability of live podcasts as well as the regular podcast. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Bornemann, and Laurie Roderiques. Music is provided by Media Sushi and Mike Noah. The ASC podcast with John Goehle is posted on Podbean and is available on all major podcast channels.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. Thank you to our sponsor, Ambulatory Healthcare Strategies. For more information about our services, please visit our website at ah-strategies.com. If you're interested in advertising or sponsoring with the ASC podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.